So right here in this picture, you see the entire tract and system laid out. So just like the gastrointestinal tract, you had organs which had a hollow, which have a lumen, and then you have solid organs. So the kidneys are the solid organs. Look at where they are present. And then from the kidneys, you have ureters, which pass down. So they are that's the part of the tract, which leads into the bladder. And then from the bladder, it leads out through the urethra. So here, when we look at the organs, so the kidneys, they are the ones they're present in the abdominal cavity. You can see lying on either side of these great vessels, the aorta and the inferior vena cava. They are the urine-producing organs. From here, after urine is produced, and it's produced by the blood that is filtered through the kidney, and we'll see that there are special functional units in the kidney called nephrons, which filter the blood, and from that, what is filtered is called filtrate. From that, certain substances are taken back, which are important. Others are pushed, wastes are pushed back, and then you get urine. That then passes into the ureter, which is present both in the abdomen and the pelvis, as you can see. So this transports urine by peristalsis. It's got a very thick muscular wall. Then it comes and is stored in the urinary bladder, which you can see is a pelvic organ. We'll later see that how it becomes abdominal only when it's full, and in little children it's an abdominal organ, because when children are born till about 6-7 years or even a little bit older, it's an abdominal organ. You know, that's why they have that pot belly, and then it sinks down into the pelvis. And then the urethra, which is in an area called the perineum, that it transports urine to the outside. So let's take a look at this video, which kind of gives you an overview of the entire system with the nephrons as well.
Florida cancer specialist with a mission to provide personalized and comprehensive oncology.
As we've just seen, the process of digestion and absorption releases nutrients into the bloodstream. But excess nutrients, salts, minerals, and water, as well as drugs and toxins, can also enter the bloodstream through the digestive system. Further, the cells of the body release toxic waste products such as ammonia, which is converted to less toxic urea by the liver, into the bloodstream. These excess materials and drugs, toxins, and wastes, if allowed to build up in the bloodstream, can threaten an individual by throwing off critical chemical balances. The blood and extracellular fluid that bathes body cells must have a close to neutral pH, precisely regulated concentrations of various salts, appropriate levels of water and dissolved substances, and of course, cellular waste products must not be allowed to reach toxic levels. The burden of maintaining proper chemical balance or homeostasis in the body falls largely on the kidneys. Human kidneys are paired, kidney bean-shaped organs located on either side of the spinal column and extending slightly above the waist. Each is approximately 13 centimeters long, 8 centimeters wide, and 2.5 centimeters thick. Blood carrying various waste enters each kidney through a renal artery. After it has been filtered, the blood exits through the renal vein. Urine, which is a mixture of water, dissolved wastes, and toxins, and some excess nutrients filtered out of the blood, leaves each kidney through a narrow muscular tube called the ureter. Peristaltic contractions drive urine through the ureter to the bladder, a hollow muscular chamber that collects and stores urine. The walls of the bladder contain smooth muscle capable of considerable expansion. Urine is retained in the bladder by two sphincter muscles located at its base, just above the juncture with the urethra. When the bladder becomes distended, receptors in the walls trigger reflexive contractions. The sphincter nearest the bladder, the internal sphincter, is open during these contractions. However, the lower or external sphincter is under voluntary control, so the reflex can be suppressed by the brain unless bladder distension becomes acute. The average adult bladder will hold about 500 milliliters, or approximately a pint of urine, but the urge to urinate is triggered by considerably smaller accumulations. Urine completes its journey to the outside through a single narrow tube called the urethra. The kidney contains a solid outer layer where urine is formed and a hollow inner chamber called the renal pelvis, which is a branched collecting chamber that funnels urine into the ureter. The outer layer of the kidney is divided into a fan-shaped inner renal medulla and an overlying renal cortex. Microscopic examination of these structures reveals an array of tiny individual filters, or nephrons. Over 1 million nephrons are packed into the cortex of each kidney, with many extending into the renal medulla. Blood is conducted to each nephron by an arteriole that branches from the renal artery. Within a cup-shaped portion of the nephron, the Bowman's capsule, the arteriole branches into a network of approximately 50 microscopic capillaries that form an intertwined mass, the glomerulus. The arteriole leaving the glomerulus is smaller in diameter than the one coming in, creating pressure within the structure that forces water and many dissolved substances such as urea, glucose, salts, amino acids, and certain vitamins through its extremely permeable capillary walls in a process called filtration. The resulting fluid, called filtrate, is collected in the Bowman's capsule for transport through the tubule.
So that kind of in a nutshell shows you how urine is actually formed and then how it passes out of the kidney into the ureters, bladder, and finally to the outside. So let's take a look at certain questions. So the first one, having looked at those pictures, where do you think the kidney is lying? So an injury to which of the following regions would involve the kidney? So you should know the 9 abdominal regions from A and P1. Okay, the kidneys lie in the lumbar region. So a little bit of it, not in the hypogastric, not in the inguinal, and certainly not in the umbilical. So let's go back to this previous picture up here, and if we drew the 9 abdominal regions as a refresher for you, somewhere here is the liver up here, and here is the stomach. Okay. So I'm going to erase that. And you take the somewhere approximately like this. This is the left hypochondrium. This is the right hypochondrium, epigastric. These are the 2 lumbar. This is the umbilical area. This is the inguinal, this is the inguinal, and this is the hypogastric, okay? So this is the lumbar region where the kidneys lie, and actually at the back, when you're looking at the posterior aspect, if this is the vertebral column, and this is the 12th rib on either side, so you're looking at the back. This angle is actually known as the renal angle. So from the back, this is where the kidney is you can feel the kidney if it is swollen, or if there's infection and you press over there, that's where the person will feel pain. So very often when anybody has pain, something to do with the kidney, they will complain of pain in this angle, in the lumbar region. They complain of back pain sometimes. So it's present in the lumbar region. Let's look at some functions as was elaborated in that video. Obviously, excretion of wastes and to maintain homeostasis. So you want to make sure that wastes don't build up. You want to make sure that the pH of the body is kept constant, so the kidneys help. Remember, the respiratory system helps to maintain pH. If your body metabolizes too much, remember you hyperventilate it to get rid of the excess carbon dioxide. But the kidneys also help that. So if, again, there was excessive metabolism, the kidneys would make sure that the carbon dioxide, which forms hydrogen ions, it will sort of make sure that that goes out in the urine. Or if the pH is very high, then the kidneys will retain hydrogen ions and pass out bicarbonate. So it helps to maintain pH. It also regulates the volume and composition of blood, because by making sure that all the electrolytes and everything that is needed is reabsorbed back into the kidney, it retains that. It regulates volume by, if suppose somebody's had hemorrhage or somebody had dehydration, then their blood volume will come down. So you do not want to be passing too much urine at that time, because if you did, you'd lose even more fluid and your blood volume will come down. So the kidneys automatically, there's a system there which kind of can sense blood pressure and blood volume, and it will bring about a set of reactions which makes sure that the amount of urine that's passed out is much less, and hence, it will help to maintain that. The kidneys also produce glucose by gluconeogenesis. Two hormones are produced by the kidney, one of which you've already done when we did blood. Remember, erythropoietin was produced by the kidneys. It produces another hormone, renin. Actually, you've heard of this. Remember when we talked of aldosterone and we said the major stimulus for aldosterone was the renin-angiotensin system. I mentioned renin at that time. Renin is actually secreted by the afferent arterioles of the kidney. And that goes and converts angiotensinogen in the liver to angiotensin 1, which then gets converted to angiotensin 2. And then that renin-angiotensin combination is what goes and causes aldosterone to be released. So you know about renin as well. And also activation of vitamin D occurs in the kidney. If you remember when we were doing the parathyroid gland and parathormone, it helps in activating vitamin D in the kidney. And this vitamin D activation is important because it helps to reabsorb calcium from the gastrointestinal tract, which is one of the functions of parathormone, that to raise serum calcium. So by activating this, it causes more calcium to be reabsorbed from the gastrointestinal tract, which is thrown into the bloodstream, and your blood calcium rises. So you can see now how a lot of systems which you did earlier are kind of coming together. So here, let's see this. So I'm already telling you what erythropoietin is important for. You should remember this from blood. So what would be the effect in a person with kidney damage? Okay, erythropoiesis was manufacture of red blood cells. So if the kidney is not producing erythropoietin, automatically your bone marrow is not going to get stimulated because it needs this erythropoietin. That's where red blood cells are manufactured. You're going to have less red blood cells being manufactured, which means if there are fewer red blood cells, that is anemia. Not bleeding disorders. Bleeding disorders would be if platelets, which are important for coagulation, they are not enough, so then your person bleeds more. Or if clotting factors, which are produced, again, in the liver, if those are not enough, again, you would have a tendency to bleed. And not in decrease in blood supply to the organs. The blood supply is based on the arteries which are going to that and how much blood flow is that to that area. So blood supply will still be enough. It's just that the oxygen carrying capacity of blood is reduced, okay? So that is anemia. So that's what will happen. And you may have seen commercials where they show that a person on dialysis, there used to be a commercial which used to say there was a grandfather who would say, oh, I'm feeling very tired. It shows that he's on dialysis. He says, I can't play with my grandson because I'm always fatigued. And the reason is because his kidneys are damaged. That's why he's on dialysis. That's why he's anemic. And when he's anemic, the oxygen carrying capacity of blood is reduced, so automatically feels tired. And then he's given synthetic erythropoietin called Procrit, and then immediately starts jumping up and is capable of playing with his grandchildren, okay? So that's why they give a person on dialysis is given synthetic erythropoietin, because kidneys are not able to do their job, so you have to give them that to maintain erythropoiesis. Let's look at the external appearance of the kidney. Again, to go back to that video, as shown, it's a bean-shaped organ, as you can see. So it has a this is the lateral surface, which is convex, this lateral border. The medial border is concave, you can see here. And along this medial border, you have this area which is called the hilum. Remember, we've done this hilum before in many structures. Can you think of another structure where we talked about the hilum? Lungs, very good. Lymph nodes was another one. Okay, hilum is where structures enter or leave. So here you can see these structures entering or leaving. The renal artery takes blood to the kidney. The vein brings blood out of the kidney, and the ureter is bringing the urine out of the kidney. So these three structures are present at the hilum. So it has the renal artery at the hilum, the renal vein, and the ureter. The vein is superficial most and the ureter is posterior most. And if we look at the kidney, if I kind of turned around the kidney, you look up here, you can see that on this medial aspect, the kidney is sort of excavated. It's like scooped out. Can you see that? It's not solid. You've got a little space here. This scooped out space is known as the renal sinus. Okay, it's kind of scooped out like that. And that's where the hilum actually opens into that renal sinus. And here is the ureter, or part of the ureter, which is known as the pelvis of the ureter. You'll have the blood vessels as well. And the in-between spaces, wherever there are gaps, you have fat filling the gaps. So they kind of helps to protect and acts like a little packing material to sort of, fill up the gaps. So here are these three structures which are present at the hilum. And then the kidney is well covered and well protected, and there are three coverings. There is an innermost covering, which you can strip off rather easily unless the kidney is diseased. So, if any of you have ever, we'll be doing this in the lab, so we'll see if you can strip it off. We'll be doing a dissection of the kidney, but otherwise, those of you try and go to the grocery store and see if you can buy kidneys, and usually they'll have this inner fibrous capsule which you can strip off quite easily. Outer to the inner fibrous capsule is a middle layer of fat, and this is peritoneal fat, which surrounds the kidney. Because it's going completely around the kidney, it's called the perirenal fat. And then outer to that is the connective tissue, which is present all around the abdominopelvic cavity. So that outermost layer is called renal fascia. Fascia is nothing but connective tissue. So let's take a look at these three coverings in a section like this, a transverse section as well as a sagittal section. So here is this is the innermost covering, which is the fibrous capsule. Then this yellow layer up here is the perirenal fat, and then this outermost here is the renal fascia. And here you can see the same thing. So the innermost is the fibrous capsule, then you have the perirenal fat covering the kidney, and then the outermost part is the renal fascia. Okay? So what do you think? Let me ask you, what do you think is the primary function of the perirenal fat? So here the operative word is primary function. Very good, yes, protection and anchorage. That means keeping it in place, which is why fat is present around many organs. And let's look at another question. What do you think would happen if the perirenal fat were depleted? Yes, the kidney would drop from its normal position. Remember, protection was one and the second was anchorage, keeping it in place. So when something is packed and kept in place and you remove the packing material, what would happen? The kidney would actually drop from that. Dropping of the kidney is similar to drooping of the kidney, so we call this ptosis. This condition where the kidney drops from its original position down, from its lumbar position. It might come down a little bit lower, is known as ptosis. This was something which was seen very often in concentration camps during World War II because those people were starved, so the body used up all the fat all over the body to make energy. So the kidneys would drop from their position, and what would happen is that when it drops, so if this was its normal position like this, it's now dropped here, the ureter remains in its original position and gets kinked. When it gets kinked, urine cannot pass out normally, so it kind of builds up in the kidney, and that leads to further problems in the kidney into a condition which is known as hydronephrosis or water in the kidney. So the kidney kind of becomes like a bag of water if it's allowed to continue. And when we are in the lab, this will really become clearer because this lab, we're going to dissect the kidney, so you actually will be able to see it. Of course, if you're taking an online lab, unfortunately, you won't. So let's look at how we describe the kidney. And again, always look for some similarity. When we did the suprarenal gland, if you remember, the cortex is always kind of an outer shell, okay? And the medulla is always the inner thing. This comes from probably from when you take a stem in botany, when you take a stem, the outer area is called the cortex and the inner part is called the pith. I don't know if they call it the medulla, but this probably comes from there. So similarly, in the kidney, if you look at that, you'll see that the outer area here is a thin strip, lighter colored. That's called the cortex. The inner zone is called the medulla up here. And when you look at the medulla is a little bit darker. And the medulla is kind of divided into triangular structures, which 3D are like pyramids, but in a section like the sagittal section, you look at them, it just looks triangular. So these are known as pyramids. They have a base, which you can see faces the cortex, and an apex, which is kind of facing the hilum, okay? You have, between 8 to 10 of these medullary pyramids. This apex the tip of the apex is known as the papilla. The papilla is always a projection. The base you can see is towards the cortex. And this zone, which is one pyramid, and let's say a little bit on the side of the medulla. So this medullary pyramid, a little part on each side, this area is known, this whole thing is called a lobe. Okay? So the lobe includes the medulla, the pyramid part of the medulla and the cortex, and a little bit of the medulla on either side. Do you see that? So there are about 8 to 10 of these lobes. This area which I'm showing you on either side, you can see it's lighter colored than the medulla. This is really cortical tissue which has come into the medulla. And this part, because it looks like a column, this area here is known as the renal column. So you can see this labeled here. So the renal column is cortical tissue which has come into the medulla. So the renal column is part of the medulla, but it's cortical tissue which has come into the medulla, okay? So therefore you can see that a lobe would be the pyramid, the cortex above it, and half of the renal column on either side. Can you see that? Okay? Then when we come down here, you can see that the papilla opens into a space. That space is known as the minor calyx. Calyx comes from, if you look at a flower, when you draw a flower, the petals kind of come out like that, and there's a part here which is called the calyx. I seem to remember calyx as being a part of a botanical term. So calyx looks somewhat like a cup-shaped structure. So this here is known, the first part here is called the minor calyx, which leads into, so you can see here is a minor calyx. So there are a few minor calyces. They lead into a larger part, which is called the major calyx. So this is the minor calyx here. So it leads into the major calyx. These major calyces then lead into a part which is dilated, which is known as the pelvis, and then the pelvis comes out and becomes the ureter. Okay? Have you followed? So you have more minor calyces, they are small, then they lead into major calyces which are fewer in number, and then all the major calyces join up and form the pelvis, and the pelvis leads finally into the ureter. The reason is that when the ureter develops, it actually develops from below. The kidney and the ureters develop separately. So the kidney develops as a mass of mesodermal tissue like this. This is the kidney which is developing. So that, and all these kind of masses of mesodermal tissue actually fuse to each other. So in the fetus, the kidney looks lobulated like this, because these masses are fused with one another. As the growth occurs, then finally it kind of smoothens out. The ureter actually develops from below. So here, let's say, I'm going to draw over this. So let's say the bladder is the part developing from. There's a little bud which is known as the ureteric bud. This grows upwards. So as it's growing up towards the kidney, it dilates, and that part where it dilates forms the pelvis. This then breaks up into few branches which are known as major calyces. So you can see there are few of them. And then major calyx divides into a few minor calyces. So it goes in and divides into minor calyces. So can you see that? So it's growing from below. But otherwise, when urine passes out, urine is formed here in the kidney. It'll pass out into minor calyx, major calyx, pelvis, ureter, and come out. And actually at this point where the papilla is opening into the minor calyx, if you actually were to look at the minor calyx, and I kind of drew it like this because it's a cup-shaped structure which is sort of where the papilla is, projecting into, there are little holes here, so that urine can actually pass out this way. Otherwise, how will urine pass out? So this area is actually sieve-like, so that urine passes out in drops into the minor calyx from the kidney, and then it'll pass all the way out. So have you followed the relationship between the two? Then let's look at the blood supply of the kidney. Now the kidney is a bit unusual, somewhat similar to, if you remember, when we did the circulatory system, and I'm using the word somewhat similar because that part is venous and this part is arterial. You remember where the portal vein was formed? And if we looked at the portal vein, it was formed by two veins, right? And how do veins join up? Veins are usually formed by capillaries, which become small venules, then small venules become larger veins, and then you finally get a big vein, right? In the portal vein, so it's the vein started out as capillaries, which formed the superior mesenteric and splenic, which joined to form the portal vein. The portal vein went into the liver, where it again broke up into capillaries, small little things which you saw at the portal triad. We've just finished that. And then they flowed towards the central vein. Many central veins joined together, and you got hepatic veins, and then it finally ended up in the inferior vena cava. So you can see there's one set of capillaries here, another set of capillaries here, right? So these were venous capillaries. The kidney is somewhat similar, but this time you have arterial capillaries. So let's just look at the way this is, and then I will show it to you up here. So from the aorta, renal artery is given out, okay? The renal artery divides into segmental arteries. There are 5, just as in the respiratory system we had bronchopulmonary segments. In the kidney we have 5 vascular segments. That means the kidney is actually divided into 5 regions which we call vascular segments. So there are 5 segmental arteries. These segmental arteries divide, there's an in-between part which they have not said. They divide into what are called lobar arteries, and then lobar go into interlobar arteries. Interlobar arteries, so they're getting smaller and smaller. Interlobar arteries, many interlobar arteries will join, and I'll show you this, into what is known as an arcuate artery. Arcuate means like an arch. So they form an arch like this at the corticomedullary junction called the arcuate artery. Arcuate arteries then branch out into structures which are called cortical radiate arteries. That means they're radiating in the cortex. The old name for this is interlobular artery. So many books still call it interlobular. The medical books still call it interlobular. Your anatomical books might have changed the name to cortical radiate. So in this video, I use the term interlobular. So they go into interlobular arteries. Interlobular give branches called afferent arterioles. The afferent arterioles break up into a capillary plexus called the glomerulus. And, you know, we saw a video last time of what is a glomerulus. It's just a capillary plexus. From this capillary plexus, another arteriole comes out, which is called the efferent arteriole. So you can see one capillary plexus here. Efferent arteriole then breaks up into peritubular capillary. So can you see two capillary plexuses? So this is still an arterial part up here, because now this is the blood getting into the kidney. You have to have the blood coming out also, which means it has to come out by means of the renal vein. So from efferent arteriole, a capillary plexus is formed, which is called peritubular capillaries, which drain into the cortical radiate vein, go back the same way, arcuate vein, interlobar, renal, and then it goes into the inferior vena cava. So you can see two sets of capillary plexuses which are formed, okay? So I'm going to show you this video, which I did. Instead of drawing it, it takes too long, so there's a video I'd drawn earlier, so I'm only going to show you the arterial end of it, and as we go along, we'll see how the venous end comes too.
So let's look at the blood supply of the kidney. So here we have the renal artery entering at the hilum. This divides into segmental branches. So there are about 5 of them. I'm only going to pick one. The segmental artery then gives off lobar branches, which are going to go towards the lobes. So let's say that's a lobar branch. Here's another one. This lobar artery now will travel between the lobes. So now it's known as interlobar. So this is called interlobar. So let's start with this. So that was the renal artery. This here is a segmental artery. So this gives segmental. The segmental gives lobar, which now gives interlobar. And the interlobar arteries then join up at the corticomedullary junction. So they join one another to form an artery which runs all along. So that looks like an arc. So that's known as the arcuate artery. So interlobar, it's arcuate. So you can see the lobar. And the arcuate artery gives off the interlobular. So that gives the interlobular. And from the interlobular, you have the afferent arterioles. So from this interlobular, you have many afferent arterioles. I'm going to draw them like that, which go to the glomerulus. So that's the pathway. So it goes from the renal artery to the segmental, to the lobar, interlobar, then arcuate, and then interlobular and afferent arteriole.
So this was just the arterial end of it. So you can see that I've kind of come up to this part. And if you follow that, the same thing is shown. The veins follow the same path, but all the way back. And then we'll see that in the next few slides. So let's look at the structural unit of the nephron. So I'm going to do the nephron first so that you understand what the structures are. Then we will put the venous end of that blood supply. So the nephron, just as when if you did the brain, you did neuron was the structural unit of the nervous system. Similarly, the structural and functional unit of the kidney is the nephron. It consists of two parts. One is the glomerulus, which is the filtering end, because the purpose of the kidney is to filter blood. And so therefore, somewhere you have to bring blood to an area, to the functional unit, and then you have to have a part where the blood is filtered. That means the red blood cells and other things are not filtered. It's only the plasma which is filtered, right? So the glomerulus is the filtering end. This is the part which is bringing blood which will be filtered. The receiving end is what is called the renal tubule. So these two structures form the nephron. The renal tubule, it's a tube, but the tube is dilated in some parts, it's very thin in some parts. The renal tubule consists of various parts. A dilated end is known as the glomerular capsule. It's also called the Bowman's capsule. And this is like, if you look up here, this is the Bowman's capsule, and this part here is the glomerulus. The Bowman's capsule is exactly like a baseball glove. So imagine if I drew a baseball glove like this, and I kind of sectioned it out. Okay, so I'm holding the baseball glove like this, and my hand is within the glove, right? There will be a layer where your baseball, which will be in contact with your baseball, and there's a part which is on the outside of your hand. Do you see that? So if I put my hand here, and here are my fingers inside. Do you understand that, right? Okay? See, understand what I'm trying to say? So this layer in the Bowman's capsule, this inside layer, which is going to be in contact with your baseball, will be called the visceral layer. And this outer layer, which is on the outside of your hand, it will be the parietal layer. And your hand is actually lying in the cavity, which we will call the Bowman space or glomerular space. Followed? It is here in the visceral layer where the capillary plexus or the glomerulus, which is in contact with. So think of the glomerulus as your baseball. Follow that? Okay? So it has a parietal and a visceral layer. The space between them is the Bowman space. From this, it leads into a convoluted part of the tubule, which is called the proximal convoluted tubule. It then dips down into a loop-like structure, which is called the loop of Henle. So the part which is descending is called the descending loop. The part which is going up is called the ascending loop. Some books just give it as the loop, but you can see just descending and ascending. It so happens that the descending has a is usually very thin, and the ascending part is thick. That means the wall is much thicker, and in the descending part, the wall is much thinner. From here, this loop of Henle now joins another convoluted part of the tube, which we call the distal convoluted tubule. So from the Bowman's capsule, proximal convoluted tubule, loop of Henle or nephron loop, and distal convoluted tubule, these form the renal tubule. Okay? And then, of course, you have the glomerulus. So together, the glomerulus and all of this part of the renal tubule form the nephron. Many such nephrons join a big duct which we call the collecting duct. So you can see these are the cut ends of the other nephrons which will join the collecting ducts. Many collecting ducts will join together and form a bigger duct which will be called the papillary duct, and that papillary duct will be the one which will open. So here these many papillary ducts, notice why we use the word papillary ducts, will open through the papilla into the minor calyx and then into the major calyx and out. Okay? So let's take a look at this to understand this better.
The renal system consists of the kidneys, the connecting arteries and veins, and the urinary tract. The kidneys are paired, bean-shaped organs lying outside the peritoneal cavity in the back of the upper abdomen, one on each side of the vertebral column. The kidneys function as the body's main excretory organ, eliminating the body's metabolic waste products by filtering the blood. Substances that are unneeded or are that are needed to maintain the normal composition of the blood. By adjusting blood composition, the kidneys are able to maintain blood volume and pressure, ensure the proper balance of sodium, chloride, potassium, calcium, hydrogen, phosphate, and pH, and eliminate products of metabolism such as urea, uric acid, and creatinine. The medial border of the kidney is indented by a deep fissure called the hilux, where the blood vessels, nerves, and ureters connect to the kidney. The kidney is composed of up to 18 lobes. Each lobe is composed of nephrons. Nephrons are the functional units of the kidney, and each kidney contains more than 1 million nephrons. Each nephron consists of a glomerulus and a system of tubules. The glomerulus is a distal coiled portion called the distal convoluted tubule, which regulates potassium, sodium, and pH, and where further dilution of the urine takes place. And the collecting tubule, which joins with several tubules to collect the filtrate and where final sodium regulation takes place.
So here she has included the collecting tubule in the renal tubule. It's usually not included. So remember, it's not in, as far as I go, it's not included in the renal tubule, okay? So now let's look at some further parts up there. Over there you saw how filtration was occurring. She mentioned something called the filtration membrane, so we'll take a look at that. So here is it's showing you the glomerulus, which is fed in by the afferent arteriole. Remember those cortical radiate arteries or interlobular arteries we talked about, and they give off the afferent arteriole. The afferent arteriole goes and breaks up into this bunch of capillaries, which we call the glomerulus. And then from this capillaries or from the glomerulus, the efferent arteriole comes out. So notice two things up here. First is the afferent arteriole diameter is much wide, much larger than the efferent arteriole diameter. This you can understand is important. So because, why do you, or let me ask you first, why do you think this is important with the afferent arteriole diameter being wider than the efferent arteriole diameter? Yes. So your answer is that it's allowing more blood to come in than going out, more nutrient-rich blood? Not quite. Yes?
Is it kind of like the lymph node where it allows it to stay in there a little longer for like extra filtration?
Very good. It is like the lymph node. You remember in the lymph node you had more afferent vessels compared to efferent vessels, so lymph came in faster than it exited, so it allowed the fluid lymph to remain in the lymph node so that the lymphocytes there could come in contact with them. It also kind of built a little pressure there. Now here we want pressure to be built up. We don't have any lymphocytes or any other function. The function is filtration, right? So what happens is that if blood flows in faster than it's going out, so what you can understand is going to stagnate here and build up a pressure. That pressure is fluid pressure, which is called hydrostatic pressure. That is what is going to be filtered, which means between the capillaries up here and the visceral layer of the Bowman's capsule, there have to be pores which are present. So think of this as a hose, which is, imagine you have this whole thing like a hose. So a big vessel here, broken up into capillaries and coming out narrow. This is the hose part, which is broken up. And imagine if you had made holes in the hose. Because of this pressure build-up over here, you can understand that fluid can filter out. This fluid will filter out better the hydrostatic pressure, isn't it? Think of it, if you had a hose which you attached to a faucet and you had a nozzle at the other end where it's narrower and you put holes in that, what will happen? The hose will kind of leak fluid out with great pressure. If at the other end was also wider, fluid will start flowing out real fast, so the filtration will be much less at the nozzle. Here is this is a similar thing to a nozzle being attached. This end is narrower, so when fluid flows in, but it's taking more time to get out, there's a pressure build-up here. Because of these little pores that we have, which we will call the filtration membrane, you'll see what it's made up of. Fluid can get filtered out from here into the Bowman space. So do you understand? That's the purpose of having a wider afferent arteriole and a narrower efferent arteriole. When we do physiology, you will see that whenever there's a hemorrhage or something, the afferent arteriole also constricts, because if someone has hemorrhage or someone is dehydrated or they've lost a lot of fluid, you do not want to be passing too much urine at that time, right? And the way you can pass less urine is if you filter less. If you filter less, less will go out. And so if you constrict this blood vessel and constrict this as well, the amount of blood going in will be much less, so you can understand the pressure will be less, so less will get filtered. Do you understand? Okay? Now here there is an apparatus which, just because I told you that the constriction occurs, so there should be something in the kidney which kind of monitors blood pressure and also monitors how much solutes are passing in, because you do not want to be indiscriminate and pass out all the solutes out of your body. So you want to make sure that if there is too much solutes in the filtrate, okay, it's okay to pass it out in the urine. If it's too little, then you want to make sure that you reabsorb all of that. Also, if the blood pressure is low, then you want to make sure that filtration decreases. If the blood pressure is high, maybe you want to increase more of the filtration. So there has to be some sort of a method to sense this. So within the afferent arteriole and the distal convoluted tubule and the ascending segment of the loop of Henle, you have something called the JG apparatus. JG stands for juxtaglomerular. Juxta meaning closed, glomerular meaning glomerulus. Juxtaglomerular. So what this juxtaglomerular apparatus consists of is juxtaglomerular cells which are present in the afferent arteriole. So within the afferent arteriole, you have cells in the smooth muscle. The smooth muscles of the cell are highly granular in the afferent arteriole. They're highly granular and they contain renin. You remember that renin-angiotensin mechanism that we talked of earlier when we were doing the endocrine system, and also when we did the functions of the kidney. I said the kidney produces renin. So it's here in the juxtaglomerular cells where in the afferent arteriole, the cells, the smooth muscle cells are granular and they contain renin, and they are known as the JG cells or juxtaglomerular cells. When the kidney, where the loop begins, the renal tubule like this tubule has kind of been pulled out, but normally what happens is that this, the white won't show, this distal convoluted tubule actually comes very close to the afferent arteriole. So normally if I was to draw it, the distal convoluted tubule would come very close to the glomerulus and the afferent arteriole. Okay, so there's the distal convoluted tubule, very close to that. So here is the distal convoluted tubule and the early part or the part just before it, which is the loop of Henle, the ascending limb of loop of Henle. The cells which are coming very close here to the afferent arteriole, these cells become highly columnar, very, very tall. They are known as macula densa cells. So the JG apparatus consists of the JG cells which belong to the afferent arteriole. They will sense blood pressure because that blood flows through them. The macula densa cell, which is part of the ascending limb of the loop of Henle and the distal convoluted tubule, the early part of the distal convoluted tubule, filtrate passes through this. So they sense the solute content in the filtrate. So the two together are known as the JG cells, a JG apparatus. So you can see therefore how they regulate blood pressure and filtrate formation. In between the two, you have certain cells which are present up here. These are known as mesangial cells. They kind of help these cells communicate with one another. So if the blood pressure is too high or the filtrate is concentration is different, they'll kind of communicate and tell the kidney what it needs to do. Okay? Now here, let's look at how filtration actually occurs. Very similar to, that's why you always kind of remember what you did before. You remember you had the respiratory membrane, which was present, the respiratory membrane was present between the alveolus up here, which has its squamous cells, and then here was a capillary which was present, which had its squamous endothelial cells, and there was that fused basement membrane. So that was a very thin area, and that's how gases could be exchanged, right? Carbon dioxide and oxygen going across. Same principle holds true over here. So here is the glomerulus, which has, these are the capillaries. So I'm going to draw the capillaries up here, which have their squamous endothelial cells. So if I draw the capillaries up here, which have their squamous endothelial cells, okay, so that was the baseball, right? So the lining of the baseball is squamous endothelial cells. Here is the Bowman's capsule like this, right? Remember I told you which was your glove which you were holding, and this was the visceral layer of the Bowman's capsule, which is this part here, the visceral layer of the Bowman's capsule. This part here would be the parietal layer. The visceral layer of the Bowman's capsule is also made up of cells which are very, very thin and squamous, and they have a special name. They are known as podocytes because they look like, they have little foot processes, which is why I call podo from the word feet. So therefore, between the capillary endothelium, the podocytes, which are the squamous cells of the visceral layer of the Bowman's capsule, and their fused basement membrane, that thin layer is the filtration membrane. So filtration will occur through that, and it has little sort of holes or what are called fenestrations, and that's what allows the filtrate to pass through. Those little pores are very small, so it only allows plasma to pass through large substances like blood cells or large proteins do not filter through. So that's why in your urine normally you will not see blood cells. Your urine is always straw colored because if it had blood cells in it, that means this filtration membrane is possibly damaged and blood cells could enter into the urine. If your urine is red, that means you have blood in the urine, right? Or of course it's a drug, some drugs, urinary antiseptics do color your urine. If you have large protein you normally do not find protein because they're very, very large molecules. They cannot negotiate those small pores. If you find protein in the urine, that means a person usually suffers from some kidney disease. Okay, so you can understand that means the filtration membranes got damaged somewhere, the pores became very large and it allowed this to pass through. Now let's look at the renal capillary bed. Now that you've understood this, the blood supply from the arterial end of it, you understood the whole nephron. And also when you saw the video, did you see that there were these capillaries lying very close to the renal tubule? Because in the kidney, what happens is that as filtration occurs, so let's go back to the previous. So as filtration occurs, goes through like this, and I said small molecules pass through. Some of the small molecules are electrolytes like sodium. Water passes through. A lot of water passes through. A chloride will pass through. Glucose will pass through. All of these substances are needed for our body, but they pass through because they are small molecules. So the kidney has to kind of reabsorb those substances. And we use the word reabsorb because absorption, remember, occurred in the gastrointestinal tract. And now all of those nutrients are passing through the kidney too, but you need to get them back into the blood. So you've got to absorb them again, so therefore you use the word reabsorption. When you reabsorb them, where do you push them? You push them back into the bloodstream. So therefore you have these blood vessels lying very close to the kidney tubules so that the reabsorption can occur easily. So notice up here is the arcuate artery. So that's the cortex, this is the medulla. Here is the cortical radiate or interlobular artery, from which the afferent arteriole comes out, forms the glomerulus. From the glomerulus, the efferent arteriole comes out. Okay? Now the efferent arteriole breaks up into a whole set of capillaries which are very close to the tubule and going around the tubule. So these are known as the peritubular capillary plexus. So these are going around the tubules which are high up in the cortex. There are some tubules which are very close to the corticomedullary junction. So with the result, you can see the loop of Henle kind of dips down low into the medulla. So here the same thing, the afferent arteriole goes in, forms the glomerulus, which forms the efferent arteriole. Instead of breaking up into what is called the peritubular capillary plexus, it breaks up into a capillary plexus with just a different name. This capillary plexus is more straight, so these are known as vasa recta. Vasa for blood vessels, recta for straight. So in either case, you see a capillary plexus. From this capillary plexus, veins will pass out, which will go to the interlobular or cortical radiate vein, arcuate vein, go back into the interlobar, lobar, and then segmental, and finally get out of the kidney in the renal vein. So you can see how blood gets out back, okay? So because these are so close, you can understand that anything that is being filtered up here and passing all the way through and coming down can go into the bloodstream. It can be reabsorbed and go into the bloodstream. It can be reabsorbed and go into the bloodstream, and that's the reason why this capillary plexus is surrounding the renal tubule so closely. Have you followed that? Okay. Okay, so let's take a look at some questions. What is the need for the glomerulus to have an arteriole feeding it and one exiting from it? Very good. To allow for filtration pressure. Arterioles have thicker walls. They are capable of constricting. Veins are very, very thin walls, very low pressure in it. So if you had a vein straight away coming out of that, you wouldn't, even if you made that narrower, you wouldn't be able to have this kind of filtration pressure. There are veins in the kidneys. We just saw the cortical radiate veins, those interlobular veins. So those veins are still there. Okay, is this true or false? Oops, it is true. Now look at this. Afferent arteriole breaks up into capillaries, which is the glomerulus. The afferent breaks up into capillaries, which is the... Oh, sorry. So the afferent arteriole breaks up into a capillary plexus. So that's the first one, which is the glomerulus. From that, the efferent arteriole comes out. The efferent also breaks up into a capillary plexus. It's called the peritubular capillaries, or it's called the vasa recta, which are capillaries. So both of them break up into capillaries. So that's why you have two of them, which is why I said it was very similar to that portal system. Here, the JG cells are smooth muscle cells in the afferent arteriole. So what do you think they would be able to sense? And here I really want you to think critically, even if you forget. Always think of what passes through it, and that should really give you the answer. Blood pressure, yes. Passing through the afferent arteriole is blood, not filtrate. Okay, so blood, therefore it can only sense blood pressure, right? Whether the blood pressure is low or whether blood pressure is very high. Filtrate, you call it filtrate when it filters out from the capillary and goes into the renal tubule, into the glomerular capsule and all that. So in the capsule, and thereafter in the renal tubule, there you have filtrate, and there you'll have solutes in the filtrate. So the macular denser cells, which belong to the ascending limb or the distal convoluted tubules, those will be the ones which will be able to sense solute content in the filtrate, because only filtrate passes through that. Blood doesn't pass through it. Remember, blood is both plasma and cells. So here, filtrate is only plasma, out of which some of the substances are not even present, okay? So macular denser senses filtrate because that's what passes through it. JG cells sense blood pressure because they're part of the afferent arteriole. So let's look at a little bit of histology. The glomerular capsule, which has those two layers, base, visceral and parietal, the epithelium has to be very, very thin, so it is squamous. And in the visceral layer, the squamous epithelial cells have a special name. They are called podocytes, and that's what they form part of the filtration membrane. And here it's showing you the filtration membrane. So here's the visceral layer, the fused basement membrane, and here you can see the fenestrated, meaning porous endothelium of the glomerulus, and this is through the area through which the blood is filtered. The proximal convoluted tubule is a highly active region. A lot of reabsorption takes place. Also some substances which are wastes, which were not filtered, but you need to secrete them and push them out in the urine. That occurs here. So the cells are very tall. So you need large surface area for reabsorption. So actually I want to make sure that you correct it, and it's reabsorption, not absorption, because you call it reabsorption in the kidney. So it's reabsorption. So you need more surface area. So here you find the cells are tall, lot of rough endoplasmic reticulum, mitochondria, they need to do a lot of work, and you have microvilli present. The distal convoluted tubules, the cells are much some amount of activity occurs here. Say if this 75 occurs here, 25% occurs here. So the cells are not as tall, much shorter. The lumen is much wider in the distal convoluted tubule. The thick segment of the loop of Henle looks very similar to the distal convoluted, not much different. And then the loop of Henle, the thin segment is thin because the cells are very, very squamous. And then when you come to the collecting ducts are also pretty similar to the distal convoluted tubule and the thick segment. It sometimes becomes very difficult histologically to differentiate between them. Next, we look at the ureter. So it begins from the pelvis. The pelvis passes into a narrower area, and in fact, there is a constriction at that point where the pelvis becomes the ureter, and that part is called the pelvi-ureteric junction. So that area is called the pelvi-ureteric junction up here. So the pelvis has narrowed and become the ureter. Then the ureter lies along the sides of the vertebral column in the abdomen, crosses this common iliac vessel, and then gets into the pelvis. So it's lying in the pelvis as well. And then it passes obliquely into the urinary bladder, and we'll see where it opens. This oblique passage is very, very important for the ureter. In fact, there are three areas where the ureter is normally constricted. One is at this point called the pelvi-ureteric junction, where the pelvis becomes the ureter of the kidney. The ureter, not ureter of the kidney. Pelvis becomes the ureter. At the second point where it's crossing what is called the pelvic brim, that's the second area where it's a bit constricted. And the third is where it passes into the urinary bladder in an oblique manner. This is important because if someone has a stone in the bladder, the stones could normally get obstructed in these areas. The ureter as it is very muscular and extremely narrow, but these are even narrower regions, so it can get obstructed and cause backup of urine. The reason why this entering the bladder obliquely becomes important is if you look at the bladder walls, if I draw the bladder like this, the ureter enters in this oblique fashion so that when the urine passes out, it kind of dribbles out this way, and the opening is very, very narrow there. So that when the bladder contracts, it squeezes the ureter and it prevents reflux of urine back into the ureter. Just like you remember how you had reflux being prevented from the stomach into the esophagus normally. So this is the normal way. If the ureter entered straight on like this, it's very easy for the urine to reflux into the bladder, and it is seen sometimes in children born like that, where the ureter is not passing through obliquely, and you might have to actually surgically make a tunnel and make the ureters pass obliquely through that. In women, there's a very important relationship of the uterine artery to the ureters. The uterine artery lies very close to the ureter. The uterine artery comes off from a branch of the internal iliac. So here's the internal iliac, and the artery comes off and crosses the ureter like this, directly across. And here's the uterus. So when you're doing what is called a hysterectomy, that means you're removing the uterus, you have to tie off the uterine arteries on either side so that you don't cause bleeding. And then you remove the uterus. You must be aware of this relationship so that you do not catch the ureter within your ligature, which is the knot that you tie. Because if you do, what will happen, you remove all the uterus and everything, but you've tied this off, you can cause necrosis and the person could end up with renal failure. So this is a relationship which is very, very important clinically. So here when we look at the ureter, extremely muscular, you can see this very, very so muscular that it throws the lumen into, you can't even see the lumen sometimes, and the lumen kind of looks very star-shaped, or what we call stellate. The ureter is lined by a special type of epithelium, which is transitional epithelium. This epithelium is capable of stretch. So the epithelium has little spaces between the stratified layers, and those cells actually drop into one another into the spaces, allowing the ureter to stretch. Also, when you look at the epithelium, if these are the epithelial cells, the top layer of the epithelium has a thin sort of deposit present, which is called the cuticle. So this thin deposit prevents water from actually entering through this and getting into the layers of the bladder. So this cuticle is impervious to urine, because urine is mainly water. Impervious to urine. Impervious means it prevents urine from passing through this and getting into the, because water can always pass through very easily through anything. But that presence of the cuticle kind of makes the ureter, and we'll see the urinary bladder, waterproof. So the inner layer is epithelium, very, very thick muscular layer, and then you have an adventitial layer on the outside. Okay? Which one? The cuticle? Yeah. Yes, it probably has more lipids in it than anything else. It is deposited by these cells themselves. Okay. So let's do a bit of review. Abdomen and pelvis, which is why it's so important to look at those pictures carefully. The kidneys are in the abdomen. The urinary bladder is in the pelvis. So the ureter joins the two. So it has to be in both. What is the thick muscle wall responsible for? Transport of urine, not filtration. Filtration occurs way up in the glomerulus, in the kidney. It transports it, and transport is by peristalsis. So actually the urine falling into the bladder falls drop by drop. Otherwise, if the urine sort of went like a big gush, you'd be going to the bathroom every now and then. So it falls drop by drop so that the bladder takes some time to fill. So let's look at this one. Suppose you had a stone where it enters the pelvis from the abdomen, so at the pelvic brim. Suppose there was a stone which was blocking that area. So which regions would kind of show up as dilated, and where would urine back up therefore? Oh, where wouldn't it would back up everywhere except, yeah, and I was wondering, my God, what, yeah, it would back up in all of these regions except. Except the urinary bladder, yes, and here's why. So that's why it's important, and instead of drawing it. So let's go back to looking at the ureter. So I said we had a stone. So here is where the stone was, somewhere here. So what happens? Urine is being formed by the kidney, comes down, can't pass through. So what happens? It's going to go back. So this area is going to back up, be dilated, will go into the pelvis, into the calyces. All of this will be there. This part and the urinary bladder would hardly get any urine into it. So that area would not back up into that. Okay. Okay, let's look at the urinary bladder. Extremely muscular organ, lies in the pelvis. It's a pelvic organ, except in children. In children, it is abdominal. It sort of comes up, which is why children have little babies and little toddlers. You can see they have a little pot belly. That's because of this abdominal. The reason is, one of the reasons, of course, is that the urinary bladder is abdominal in them. It takes some time. By puberty, it kind of comes down and lies in the pelvis. And in us, it becomes abdominal when the bladder fills. So when your bladder is filling, and then, it's sort of from the pelvic area, it goes up, and when you have about 500 ml, then it is truly abdominal at that time. You can feel that bladder pain just above your pubic symphysis. If you look at the bladder, it has, when you look at it in the lab, it's kind of all collapsed, but if we were to kind of give it surfaces and borders, we can see it has a superior surface here. These would be the lateral surfaces on either side, and that at the back would be the posterior surface. Okay, so that's how the bladder is. This area here is narrowed. This area is called the bladder neck, where it narrows and goes into the urethra, lined by transitional epithelium. A bit similar to the stomach, in that when you look at the bladder in an undistended state, it is kind of folded, it looks very trabeculated. So those are known as rugae, which kind of smoothen out when the bladder is full. But there's one area which is smooth normally, so that area doesn't have any rugae. That looks like a triangle on the posterior walls. It's triangular in shape, so that's called the trigone. And at the trigone, you have 3 orifices. You have the orifices of the 2 ureters at either end up here, and at this point, which is the bladder neck, is the orifice of the urethra, which leads into the urethra. So we have 2 ureteric orifices, and this one is known as the internal urethral orifice, which is guarded by a sphincter. Obviously, it has to be guarded by a sphincter, which is involuntary. It is also called the internal urethral meatus, or internal urethral orifice. And there's that involuntary sphincter which guards it, because you have to have a sphincter up there, otherwise urine would keep dribbling into the urethra. The lining, as I said, is transitional. Very thick middle layer of smooth muscle, and in the bladder it has a special name. The bladder muscle is called detrusor, and it is this detrusor which is thickened up here to form that involuntary sphincter. And then the outermost layer is connective tissue, except on the top where it is covered by peritoneum. So up here is the peritoneum covering it, but otherwise you can see on the sides and posteriorly there's no peritoneum present there. So let's answer this question so that let me see if you know where exactly the bladder lies. Which area is it related to in the pelvis? Very good. Pubic symphysis. The bladder is a pelvic organ lying just behind the pubic symphysis. Your rectum is in contact with the sacrum. So if you took a side view, this would be your pubic symphysis. Here is your vertebral column. Here is your bladder. And here is the rectum and anal canal. Okay, so the bladder is right next to the pubic symphysis. So in automobile accidents where something passes through the pubic symphysis, injures the bladder. The nerve supply of the bladder is rather important because that is part of what is called the micturition reflex. A bit similar to gastrointestinal tract. Remember, in the gastrointestinal tract, the parasympathetic system contracted the muscle but relaxed the sphincters. The sympathetic system was the one which kept the sphincters contracted. Same thing up here. So the parasympathetic system stimulates the detrusor muscle but relaxes that internal involuntary sphincter. The sympathetic system is the one which keeps that sphincter contracted. Okay? So when your bladder is filling, the two of them are working hand in hand. The parasympathetic is relaxed at that time. The sympathetic is more active at that time, keeping the sphincter closed. When you want to micturate, the parasympathetic takes over, sympathetic relaxes, so what happens? The detrusor muscle contracts and urine is pushed out. Now we have another sphincter, which is the external voluntary sphincter, which surrounds the lower part of the urethra. That is voluntary, so even though this sphincter wants to relax and you want to pass urine, you have the ability to control your urine to some extent, because if the time and place is not proper, then your brain centers will depress the urge to micturate, and you can hold your urine. Now you can hold urine till usually by when your bladder fills to about 350 ml, you have the urge to micturate. But you don't, but the bladder can continue to fill. If it fills up to about 500, then it gets really painful, then you really feel pain. Now, unlike defecation, which you can control a lot more, when the bladder fills to a certain extent, what happens is that the pressure inside builds up so much that even your involuntary and voluntary sphincters kind of open up, and sometimes you can have what is known as urge incontinence. That is, there is an urgency to pass urine, and because it's filled up so much that just because of the pressure, both kind of relax, and incontinence can occur. So let's look at how micturition occurs.
The micturition reflex involves impulses traveling from the urinary bladder to the sacral region of the spinal cord, and from the sacral region of the spinal cord back to the bladder. It is coordinated by neurons in the spinal cord and can be influenced by signals from the brain. When the urinary bladder becomes stretched, there is an increase in the frequency of action potentials carried from the bladder wall to the sacral region of the spinal cord. In response, parasympathetic neurons from the spinal cord to the bladder are activated, and this causes the smooth muscle on the bladder wall to contract. The sensory signal to the sacral region of the spinal cord also stimulate ascending pathways to the pons and cerebrum, which results in a conscious desire to urinate. If urination is not convenient at the time, the brain sends impulses down the spinal cord to inhibit the micturition reflex. Impulses carried via somatic motor neurons keep the external urinary sphincter contracted, which also prevents urination. When urination is desired, signals from the brain stimulate the micturition reflex. The brain also decreases action potentials in the somatic motor neurons to relax the external urinary sphincter.
In little children, the reason they wet their bed so often is because the higher brain center control hasn't been established. It takes some time to establish that. That's why they have what is called enuresis or bedwetting. Okay, so let's take a look at this. What does passage of urine involve? Very good. Contraction of the muscle and relaxation of the sphincters. Parasympathetic. Sympathetic causes contraction of the internal sphincter and relaxation of the muscle. And somatic is external, because that external sphincter is skeletal muscle. Then let's look at the urethra, and I just caught a spelling up here. This should say neck. So the urethra begins at the bladder neck and travels to the external urethral orifice. So there are two sphincters present in the urethra. One is this internal sphincter, which is at the bladder neck up here, and that internal sphincter is involuntary in nature. So up here, internal sphincter, you can see here at the bladder neck, involuntary. And then as the urethra passes through an area called the perineum, you have an external sphincter. Here, this external sphincter is the voluntary sphincter. So here also you can see that. Now in males, you have the urethra is much longer. It's about 20 centimeters long. It has various parts to it. There's a part which passes through the prostate gland called prostatic urethra. Then there's a part where it passes through the perineum. The perineum is the area between the thighs in front, okay, the genital area. So this area is, there are two membranes present here. So this part is called the membranous urethra. And then it goes into the penis. So this is called penile urethra, or also called spongy urethra. And we'll see because it passes through something called the corpus spongiosum. That's why it's called spongy urethra. The female urethra is only 4 centimeters long, just 4 centimeters long, and they say it is kind of the equivalent of the prostatic and the membranous part of the urethra. So here's a question. Who do you think is more prone to urinary infections and why? Very good, yes, females, shorter, closer to the vagina and anal canal, and there are a lot of bacteria in the vagina, so can easily pass through because both urethra and the vaginal opening are in an area called the vestibule. Let's look at some clinical conditions. Urinary tract infections, quite common, as I said, in females, and that's why little girls are taught from very earlier on, proper hygiene. Urinary tract infections or any infection in the kidney, which is where the glomerulus is infected, that is known as glomerulonephritis. Nephritis means inflammation of the kidney. It could be part of the glomerulus which is involved. It could be a part of the renal tubule which is involved, which we call pyelonephritis. And then urinary tract infection. All of them kind of inflame the tract, they inflame the parts in the kidney, and they can lead to blood passing out in the urine, which is known as hematuria. Hematuria is blood passing out in the urine. Normally, whenever we give urinary drugs to take care of urinary infections, we want those drugs to be secreted into the renal tubule so that, that's where the action can occur. So many of these drugs actually color the urine. Sometimes they color it a bit orangish. That is not hematuria. Hematuria is actually seeing red blood cells in the urine. Okay, that coloring of the urine is not because of blood cells coming. That's just one of the effects which is seen when you give drugs for urine. And sometimes some other drugs too, when they are passed out in the urine, they may kind of color the urine a bit different.
Blood in your urine, is it red?
It is red. Blood in the urine is red. Is definitely red. Incontinence is a condition where you're unable to control, the urge to urinate, so the sphincters are relaxed and you pass out. As you get older, and younger children have incontinence, younger children because the pons, the pathway, the brain centers have not developed. Older people, reflexes are a bit slow, they may have some sort of problems, and then even in spinal cord injury, especially the lower level, people could have this incontinence. Stones in the bladder, in the kidney, or in the ureter are called calculi. So you can have calculi in the kidney, you call them renal calculus. This renal calculus has to pass out. When it passes into the ureter, you call it ureteric calculus, and the ureter tries to pass it out. It's a foreign body there. It's an extremely painful condition. And then when it comes into the bladder, then we call it a vesical calculus. Here is a calculus which you can see up here, so ureteric calculus. And this is, in order to investigate wherever we see an obstruction, we do something known as intravenous urogram or pyelogram. It's called urogram or pyelogram. IVU or IVP. And so you inject a dye into the vein, the dye goes into the bloodstream, it is filtered by the kidneys, and then you can see the entire tract up here. Now you can see on this side an intravenous, this was a plain x-ray, an intravenous urogram was done. So this side is kind of come out pretty normally, and up here, because of the obstruction, notice how this ureter is so enlarged, and you can look at the calyceal system has become really, really enlarged up here. So this kind of intravenous urogram tells you where the obstruction is. Cystoscopy is a method of looking into the interior of the bladder, where you kind of want to look at if there is a cancer there, if there are any tumors growing or anything. And this is a nice video which shows you, when you look into the interior of the bladder, what it looks like. And you can also see how the ureteric orifices are really, really very, very small. So let's take a look at this. So there's just music, no audio, so just follow along. So you're passing through a male urethra, so it's very long. So the scope, the cystoscope, is a light, usually has a light at the other end, so you can see it's passing through the urethra. This area is part of the prostatic urethra. Still in the prostate. And then now you enter into the bladder. So look at the bladder wall. You can see how it's trabeculated. Here is the ureteric orifice. Notice how bladder wall, and it's just sort of going through all the, these are things which float around in the urine, in the bladder. Now this person has a tumor, so the small bladder tumor up here. So within the scope you can do a biopsy. So notice how they take a piece of it. And obviously there's going to be some bleeding, so you cauterize that area. You can see that area is cauterized. It'll heal on its own, and you take it out.